Now starting. All attendees are in listen-only mode.
Good afternoon and welcome to today's presentation, Successfully Integrate Telehealth into Your Clinical Workflow. Today's executive web briefing is brought to you by Open Minds and sponsored by Welligent. This afternoon, we're joined by Deb Adler, Senior Associate at Open Minds, and Rich Daly, Director of Sales at Welligent. During our time together, we'll describe key strategies to take your telehealth solution to the next level and demonstrate Welligent Telehealth, a key component of Welligent's customer engagement toolkit. You may notice that all attendees have been muted for today's presentation. We are recording today's event, and muting the phone lines improves the sound quality of the recording. However, we do encourage you to submit questions via the question box on the GoToWebinar panel at any time throughout the presentation. At the end of the presentation, we'll hold a brief question and answer session. Now I'll turn the floor over to Deb.
Thank you. I'm very excited about speaking with you today about this important topic, telehealth. I've had the good fortune over the past nearly 20 years to have worked in this space. Believe it or not, telehealth isn't completely new. Even I know I was involved back in the 90s when most telehealth was delivered to Medicaid populations in a site-to-site approach. So the individual had to go into a site and would be remotely seen by, let's say, a virtual psychiatrist at another site. And that model still exists today, but now we have the ability to treat it in any place that's private and safe and secure, including your own home. So just a little about me. Most of my time has been in the payer space. I led network strategy for Optum for 9 years and also worked with other payer organizations. So much of my time in the payer space, and have really enjoyed working with Open Minds as a senior associate, helping to consult on a variety of topics. The one that we're featuring today, in fact. So we're gonna, before we jump into the content, I believe we're gonna start with a poll to understand our audience a little better. So we wanted to understand if before this pandemic, did you have an existing telehealth strategy for your organization? So we'll give folks about 30 seconds to answer. And I have the luxury of watching the poll in progress. I'll give you the response here in just a second. Yes, it looks like many of you did not. That's interesting. So nearly 60% prior to COVID did not have a telehealth strategy. 42% did. I would guess that those that did may have used telehealth on a relatively smaller basis. I know many of the provider organizations I work with had maybe less than 5% of their services delivered through telehealth, and that shifted overnight around mid-May to keep your doors wide open. You really had to make that shift and transition. So that's interesting. We'll talk more about the no's because if you haven't made that shift, I strongly believe that telehealth is here to stay. But we'll talk a little bit about how the telehealth landscape has changed. So if we could go to the next slide. A number of things have changed, particularly consumer adoption, the regulatory environment, payer support, and then the populations that can now be served through telehealth. I know when I worked for payers, if we had 1 to 2% of our outpatient visits delivered through telehealth, we were actually excited because there was a real hope and desire to see that adoption level by consumers, but it just wasn't, awareness was just not present for the most part. Many individuals, and I would say as of several years ago, most of the health plans had made telehealth part of the consumer's benefit plan, but many didn't even understand that they could use telehealth in lieu of a face-to-face visit. So awareness was one of the key changes that COVID brought along the pike. The other change was allowing approaches that were not previously reimbursed. So In today's environment, although that door is closing soon, in today's environment, most of the payers will allow for some phone-only visits. There are some exceptions to that, but recognizing that individuals are social distancing or may not be able to leave their home, there has been some allowance for phone-only delivery of services. I would suggest that is going to be a fleeting capability for folks, and we'll talk about the payers and how many are already beginning to identify some end dates to their allowance for those types of services. The other change that occurred with COVID is the allowance by the Office of Civil Rights to accommodate non-HIPAA secure formats. And that would be another example of something that I would expect to see retrench or change soon as, you know, again, we get back to the new normal post-COVID. New services have now been accommodated by telehealth. A great example is in the autism space, applied behavioral analysis. In the past, there wasn't really much accommodation for telehealth other than being used as a tool for supervision or maybe even parent training. That's now opened up more broadly, so many services, to the extent that the child can participate, can be delivered and reimbursed for through telehealth. So it's another, you know, really broad opening of capability. The other thing I would say is you'll see as examples here, you know, that certainly organizations, companies like Zoom saw, you know, an immediate increase, right, when everyone scrambled to find a means to continue to stay connected, not just for meetings, but also delivery of services. I would highlight, and we'll talk about this throughout, is, you know, there is certainly a HIPAA secure version of Zoom, but you do want to make sure as you're selecting telehealth programs going forward that you're picking something that's not only HIPAA secure, but also allows you to really integrate that service into your clinical workflow and your other billing and other services. And we'll again talk more about that, but you can get pretty unwieldy to have to, you know, not only manage your typical clinical workflow, but then to subsequent to that have to, you know, separately handle all of those other services. But again, big boom in use. In fact, we now have a new word in our lexicon, which is the Zoom bombing that began to take place, and threats to privacy and security in working with individuals through a product like that. I would say on the right-hand side, you'll see, you know, a lot of the telehealth vendors certainly saw huge increases. That's really just an example of the adoption rates. And then one of the payers, Beacon, recently published their increase in use, and it's just phenomenal. How, you know, I think what I would say is now that the cat's out of the bag, it's going to be really hard to stuff it back in, because consumers have now recognized that this is a convenient mechanism for treatment, and the provider community and research shows it's also an effective approach to delivering services. So let's go to the next slide. I want to give you a few examples from the payers, because I would suspect many of you are from provider organizations. Some may also be from payer organizations. And it's important to stay on top of what the payers are promulgating as it relates to telehealth. So if we go to the next slide, and I would highlight the lesson learned here is to check, and to check often. So I'm going to use 3 national payers, but I would suspect many on the phone are working with regional payers. You may be working with Medicaid specific or commercial specific contracts. So I would say check often about what they're publicly posting. I was really delighted to read just yesterday that Blue Cross Blue Shield of Tennessee has already decided that they are going to retain their telehealth policies post-COVID. So they intend to continue to support many of the things that they've implemented during COVID. But let's look at some examples. The first is a cost share waivers, taking out the copay or co-insurance requirements if individuals seeking outpatient behavioral health or outpatient addiction services, helping to drop down any barriers that might be in the way of getting services through telehealth. So Aetna, as an example, has removed copays and cost share through June 6th, as you can see, as it relates to many behavioral health and substance use outpatient services, including not just outpatient, but partial hospitalization and intensive outpatient. Cigna, you'll see, has not done any cost share or copay waivers, so they have made a decision not to do that, but they are allowing for a 5 to 10 minute phone conversation and will waive the cost share for that. As you can guess, there's a very specific code, and the reimbursement is going to be at a level commensurate with 5 to 10 minutes. Optum, on the other hand, has waived copays during this COVID window, if you will, and they recently extended that window until June 18th. So again, lesson learned, make sure you're checking. If you go to the next slide, the other thing to be keenly aware of as a practice organization is making sure you're billing correctly. And I've heard some recent challenges from provider organizations who have received a number of denials for payment. So again, this is often publicized by your payer on their website, but just to show some examples, which I think are kind of intriguing. Aetna, for example, has done a really great job of specifying which codes can be used for telehealth, what types of modifiers they want added, or place of service code being 2 for telehealth. And I think it's really interesting, the neuropsych codes are included in that suite, as are most of the evaluation and management and typical outpatient codes. Cigna, you'll see a theme here, right? Most are saying make sure when you bill, you can just use the standard codes, but make sure that you include the appropriate modifier or place of service to indicate it was delivered through this modality. And I would say payers are actually pretty excited to see their numbers rise, because it has been a goal of many of the payers to really increase, particularly on the outpatient side of the fence, increase the volume of services delivered through this means. And then Optum, and the other highlight I would say is many of the payers require you to attest that you are using a HIPAA secure platform. So Optum is a great example of that. You can go out to their website, their provider portal, providerexpress.com, and they have very detailed information about their expectations if you are delivering telehealth. And one of them is that you complete an attestation that you're using a HIPAA secure platform. Now they're waiving that during this COVID period through, June 18th for Optum. But if you're currently using telehealth, not on a HIPAA secure platform, you need to be making a move onto one soon, and you need to make sure that you have on your contract the required codes and the required attestations necessary to continue to deliver telehealth services. And then last, I think on the last slide, again, how telehealth is defined. Generally, it's not defined. I think I skip to slide 8. Generally, the focus is on real-time, synchronous, audiovisual connection. So you can see that is the desire by the payers and the regulators. This small window of time where phone only is allowed, I would highly anticipate will be ending, probably by mid-June. I also, if you go to the next slide, I want to talk a little bit about regulatory resources, because the exciting thing, if your organization is transitioning to telehealth, is this can open up not only new populations, but also open up new geographies for you. So if you're a practice in, let's say, Lanham, Maryland, outside of DC, and really most of your constituents, most of your consumers were within a 25-mile radius, with telehealth services, assuming that the service can be delivered through telehealth, you can now expand your practice from that 25-minute radius around Lanham, Maryland, to the entire state of Maryland, because the regulatory rules pre-COVID and anticipated to stay in place post-COVID are, if the provider delivering the service must be licensed in the state where the consumer or member resides. So if you have a Maryland licensure, let's say you're a psychiatrist with a Maryland licensure, you can deliver services to residents of Maryland because the regs allow for that to occur. In this window of time with COVID, many of the licensing rules are more relaxed, or you can often get temporary licensure. So I'm aware of a Maryland-based psychiatrist who was able to get a New Jersey license within hours because of the expanded need for services, not just medical services, but mental health services that have been generated through this COVID-19 event, has really increased the demand for behavioral health services. And so given it's such a workforce challenge, a workforce shortage in behavioral health, many of the states are really opening their doors and relaxing the rules to allow for more individuals to deliver services across state lines. Some require a bit of a wait period and a more extensive review process, but others have been in such a state of need that they've allowed for temporary licensure to begin immediately. Nevada is another great example. If you're licensed in another state, very easy to open up services on an outpatient basis in Nevada because the licensure rules allow for very quick access to temporary licensure. So what I've provided you on this slide is some resources. The FSMB, the Federation of State Medical Boards, is for the physicians in the audience or those that are working with physicians. But there's some other great sites here as well. The Association for Social Work Boards has terrific information. You can just drop down and look at the state you're in or you're licensed in and see what are the efforts required if I want to get cross licensure. So again, great time to really expand your practice and look at new markets within your state and maybe across state lines. Other good resources on this page, the American Telemed Organization and Center for Connected Health Policy do a great job of continually updating the new requirements. So something to pay close attention to because it's certainly a terrific opportunity for growth. I'm going to go to the next slide and talk a little bit about making the transition. So only 40% of you had telehealth prior to COVID. So, and so a lot of you, I would suspect, had to pivot rapidly. And I'm very aware of organizations who have truly pivoted overnight. I would suspect that was a huge challenge and a lot of lessons learned as a result. These are some lessons learned and recommendations from working with a number of provider organizations who made that swift pivot. First and foremost, the clinical training to transfer those skills to a new modality is important. A lot of providers that entered the field, particularly the behavioral health field, have most of their training is centered on face-to-face interaction. So being able to transition those skills to a new modality does take some training and transfer. you know, even simple things. I always say I would be terrible at this. Simple things like, you know, making sure the camera is in the right place, that you're having eye contact by looking at the camera, not the person on the screen. A number of tips and techniques, which we'll talk about in a little bit. The other is the consumer training to make it a positive therapeutic response for the consumer. I've heard many stories of individuals, including myself, who have, you know, had to help their parents, right, implement these types of telehealth supports also overnight. So engaging the consumer as well as their caregiver can be a very important component to make sure that it's a positive experience and one that the consumer wants to continue. Some of the successful things I've seen organizations do is to disseminate guidelines to both their consumer constituents, caregiver constituents, as well as their own staff. You know, giving them recommendations. One that I particularly liked is an organization that offered group therapy, now having to do it through virtual means. So they needed to set up protocols to make sure that individuals that were entering into the group were making sure that they were providing their first name only, no last names, to protect their privacy. They set up waiting rooms, virtual waiting rooms, so that the individual leading the group could assure that each person entering the group was in a safe, private, secure setting, appropriate setting, before they, you know, open the door, if you will, into the group to begin the program. Although when you hear that, also remember that's some additional time, right? So you might need extra time before you start your service, right, to make sure all of those important guidelines and components are ready and adhered to. And certainly risk and safety protocols are important as well. Having in place a crisis plan, understanding the individual's emergency contacts before you enter into the service, and making sure that any consents have been collected as well. So there's a lot of things to think about. I like some of the quotes from some colleagues of mine who have been through this process. And I would say, by and large, it's often the providers that have a harder challenge with making this change than the consumers. And one thing that has to be continually reinforced to both the consumers and the providers is that this is a safe and effective approach. Any change is hard, right? And you might find in your organization it's harder for some than others. Jen Dorsey there from Colmac Clinic spent a lot of time during their transition to telehealth from fully face-to-face world by having one-to-ones with clinical staff, you know, because it was embarrassing for some to say, you know, gee, I'm having trouble with with how to manage a group and manage it this way. So she conducted a lot of one-to-one training and support. The other thing to think about is, you know, how does this integrate with your current EHR system? You know, how, you know, now that we're performing our functions this way, how does the provider, you know, complete their progress notes, assign a diagnosis? Do they now need to plan differently? And we'll talk about, you know, the value of having an integrated program. And then last but not least, there's staff training, new expenses to think of, right? That, you know, people didn't have laptops working from home that were company paid for. How do you manage that? And the coding changes, et cetera. I think one piece of good news that I do want to mention as we turn, you know, the one thing that's been terrific in behavioral health, because of our workforce shortage, most of the payers pay the same rate of reimbursement, whether the service is delivered face-to-face versus virtually. And I you know, certainly don't have a crystal ball. That has been the approach for many years now. And I think it, you know, I think there's I would predict that will largely hold true for the near term, because there's a great recognition that The service is so important and access is such a challenge that to discount the reimbursement for a telehealth visit could be very problematic and hurt access to care. So that's not true so much on the medical side of the fence. If I had pink eye and needed to call up a medical provider via telehealth, I would have the same copay, but the provider would probably get a lower reimbursement for that medical service. But fortunately for behavioral health services, there's not been typically a discount. So I think that's the good news about behavioral health, telehealth, and addiction. So let's go to the next slide. I wanted to talk a little bit about, how do you make this a smooth transition for your practice? What are some tips? And this is from an individual whose entire practice has been delivered through telehealth, their outpatient practice, for many years. It's, they don't do any face-to-face work, but so I think they have some really great suggestions. Some I've mentioned already, keeping making sure that the computer's in the right place, you're in a quiet, well-lit room, that you are, it's private, it looks professional, and that you're really setting out dedicated time. I mean, it may sound silly, but I've seen providers, eat their lunch during the treatment. You wouldn't do that in a face-to-face world. You shouldn't do that via telehealth. You need to make sure that your appointments may have to be managed a little differently. We talked about, there may be some preparation time that you didn't have to plan for in a face-to-face world that's different with telehealth. I do think, and she says too, that if you have a integrated platform where the treatment planning and progress notes can be captured while you're having the service, that makes it so much easier and nicer, and really streamlines your clinical workflow. Some of the clinical benefits, certainly the obvious one, that the patient doesn't have to travel, and it may take out the stigma. People, may be uncomfortable even just pulling into the parking lot of a behavioral health program, right? So it can be a way of removing the stigma, certainly saves time. And for the therapist or the deliverer of the service, you get to know a little bit more about the client and their personal space. So it may be a great way of establishing fast rapport with them as well, and use that as part of the conversation and connection. And then last but not least, it's another way to expand your skills. I know many providers that I've worked with that pivoted fully to virtual during COVID now are offering weekend appointments, evening appointments. They've set up groups for different populations. They can have more homogeneous groups of individuals rather than some of the limitations they felt in their face-to-face practice. So I'm going to introduce one last poll before I go into the next slide. Rachel, one thing we were curious about is if your current telehealth solution is integrated with your clinical and billing systems. My experience is most folks in this rapid need to move quickly to keep their doors open really just layered on top another product, right? You can name whatever product it is, maybe HIPAA secure, maybe not. I have seen fewer practices with an integrated system that really allows them to, capture the progress notes, do the billing, complete the important information needed, that really, turns this in from an add-on activity into something that's much more streamlined. So what we're seeing so far in the poll, a quarter of you, I'm even surprised it's that high, a quarter of you do have a telehealth solution that's integrated with your clinical and billing systems. That's pretty remarkable, because again, I bet that a lot of those 25% may have had a solution pre-COVID because it does take some forward thinking and planning to be in that place. Great, thanks, Rachel. So with that, again, I want to highlight that I think integrating and if you go to the next slide, integrating and expanding telehealth can be, you know, as I mentioned before, a great way to move from a practice environment that has geographic boundaries to something that allows you to be statewide or even open up to new markets. And I would say be speedy if you want to use the COVID window of time to add new licensures and new markets, because this is a great time to check out those regulatory resources to do so. It's also a great time to add new service lines. You know, maybe you weren't offering autism services or using telehealth for some of the populations that could now use it. Think about, you know, if you're mostly serving adults, is this a way to start opening up to teens and adolescents and others, you know, keeping in mind the informed consent and other requirements. This can open up more flexible access and new populations. But by and large, I do think there's great value in finding a product that can, you know, really integrate your services. We mentioned before that, you know, if you have 15 minutes to prepare, then you do your session, then you spend another 15 minutes writing your progress note, another 15 minutes billing. If you think about the sequential process that you might have today, you could save a lot of time and money if you could move into a more integrated parallel process of managing the, you know, clinical, administrative, billing functions, et cetera, as part of your telehealth delivery. So with that, I'm going to turn it over to Rich, who's going to give you a demo of an integrated product.
Great. I'm going to show my screen. Deb, let me know if you can see everything okay.
I can.
Great. So I'm going to try to hide my GoToMeeting. I can't tell if you can see that or not. I'm just going to close the panel. So the first thing that I wanted to show you is really the product that's designed for those who are not currently using the Welligent EHR. So as COVID kind of started ramping up, we realized that we wanted to make things a little bit easier for our client base to really start opening video conferences quickly and simply, already in the same workflow that they were used to going through for their traditional service lines. All that was really changing was the setting. So we wanted to offer a level of integration that kind of led to some clinical efficiencies and made things really easy on the client. So I'm going to show you how we've integrated that into a few of our actual clinical workflows. But what I have as my home screen set here is my video conferences screen. This is a part of our standalone client engagement toolkit for those who may not have a change in EHR in the cards right now. It's relatively easy to use. I'm going to simply start a new conference right now. This is going to pull in automatically my video conference, but I can change the title. So if I wanted to make sure I wasn't incorporating too much clinical information, if any, I can simply say Rich and Andy appointment. See that I'll catch my mistypes too. I'm going to say we're doing this right away today on the 21st. At the time that's on my computer. I might say that I'm anticipating this to take only 30 minutes, but this is not a required field, as you might see with the red asterisk. I'm going to default this to delivering by email. However, we do have the ability to send this via text as well, if that's your client's preference. And then I can choose a couple other things. Do I want to include a signature queue for clinical documents? Is this going out to a Spanish-speaking client? Do we want to include that text on the invite? So I'm going to save the record. This is telling me if I missed anything in the required fields, and I'll keep this really simple and just do 5, 4, 3, 2, 1. So as I save this, I have the ability to pull in my participant. I'm going to add my standard invite. This is what's going to show up either in the email or the text to the client. So I need to add the client next. I can search through my database of clients. I can look at any other stakeholders, maybe family contacts for the client, other providers at my agency, or even some external stakeholders, maybe your referral sources for a warm handoff. Now, if somebody doesn't fit any of those categories, I'm going to simply click Other, and I'm going to put it in randomly. I'm going to send this to Andy, and I'm going to add him to my participant list. So once I've added Andy, it's going to show up that he's an other type of participant, and I can return to my front screen and see all the information that I need. So in this case, all I did was his first and last name and his email, which is all that I needed to send him the invite, and I'm going to click Send. As a provider, from here, all I need to do is click to start my conference. I'm going to accept the terms and conditions and put in my password. Now, we tried to make this as frictionless as possible for both the provider and the client. So there was originally an option to download an app, and we thought that it was just a little bit easier to force it to go through the browser. So that's how I'm going to do it. You'll see as I start this that I am now on the screen. I have to work on putting a checkbox in to do a hair check before we start the conference. I can choose my camera, my microphone, and which speaker I want the voice to come through, and then decide if I want to share my window. You also see the End Conference button, and that's just a simple way for the provider to have the ability to shut the conference down so that no one else can join or remain on the call if you were doing a group. But I'm ready to start my conference, so I'm going to hit the green button and jump in. Now, please keep in mind that as we do this, we are running two systems at the same time with GoToMeeting and our system. So Andy's joined. I still have my preview in the bottom. Andy, we got to work on the eye contact. We have to look right into the camera and smile. There's a couple of different things we can do while we're on the call. We can do an integrated text chat. So I can send a quick message to Andy. And he can reply. It's important to note that there's no recording, neither of the video, audio, or chat throughout these conferences. So this is all one time, not saved anywhere, an extra HIPAA compliant feature. So if I'm ready to end the conference with Andy, I can click that and it's going to shut it off for all of us. Now, Andy answered there on his computer, as you might have guessed based on his computer chair, but the client can certainly open from their phone or tablet. It's just going to take them right into their browser, and I can concurrently document at the same time. So I'd like to show you what that looks like. I'm going to start with an individual note that I have on my calendar for the day. So I'm going to open up John, and you'll see that all I need to do is the same process that I had already walked you through. From my note, this is going to give me a bit of a reminder for things that I have that are coming due or are overdue. And all I need to do is start my conference or add other participants if necessary. So I put Andy's email in for test John here. It's going to strike through his cell phone because in his record, he's identified his email as his preferred method of contact. So it's going to make sure it goes here. Now, because this was a scheduled appointment, I have a couple things that are already pulled in for me, like my topic, start and end times, and even a password, which is auto-generated. So we'd follow the exact same process that we just did. I can start my conference, or if I'd like to loop somebody else in, I can add additional participants here. So while I'm talking to Andy face-to-face, I can retain my note on the same screen, or two if you have two monitors, complete my documentation, and make sure I have everything completed in the way that I need to get the bill to go out properly, which might include a simple checkbox for telehealth to add the modifier to the claim. We've also integrated this into our group notes. So if you do have a group that you meet with on a weekly basis, right now with social distancing, that's not necessarily something that can happen. So we have the ability to send that same video conference invite to all of those involved in a single group. So I have 7 participants in this group. I can go through the exact same process of making sure I have all of their details appropriately. Do I have emails or cell phones for everyone? And I can always add additional participants if new ones join during the session. Once you jump into a group session, you will notice it's very similar to a lot of the other video conferencing platforms that you might be familiar with. You'll show up as tiles. Within that group stream, you can see face-to-face multiple people at the same time. And again, I have the ability to document my note, without going anywhere else. So those are really the first two simplified integrated techniques. There's a few others that I think are very important to us. We have the ability to create a video conference on the fly here in the video conference screen, and that's accessible right in your communication center with a few of our other tools in the client engagement toolkit, like bulk emails and texts. This is obviously a relatively new feature for a lot of clients in behavioral health, and you might want to send out a quick notice that telehealth is available. You can start having your sessions with your clinician virtually rather than meeting in person at a specific location. So I can send this to all clients of a certain program, identify a simple text-based message for those who aren't opening via email, and even incorporate graphics and some other word processing features. Message comes out very nice and polished, and you can create as many of these as you need to. Another workflow that we identified as logical to incorporate video conferencing is through our call center. So whether a client is calling to do an intake and you'd like to meet with them face-to-face virtually, or if it might be a client calling in who's in crisis, you have the ability to jump into that managed conference screen right from here, document your call, any call notes, and make sure that you have a chance to connect with your client face-to-face and virtually via voice, so that it's a complete set of documentation and you have a chance to see where the client is and what's going on with it. We've tried to identify a couple other areas that are key to some of our customers, including our home and community manager for those providing IDD services in group homes, supported living arrangements, or really any other residential facility. We've included it on our staff supervision note. So if there was a situation where you were reviewing documentation for one of your providers as a supervisor, you can start a video conference with them right now as nobody's going into the office and document your supervision notes while you speak face-to-face with your teammate. The last that we have to mention is in our foster care manager. You have the ability to communicate with your foster care parents as you're going through compliance checks, going through the process of certifying a parent to be able to host a child in their home. So we've tried to make it as seamless as possible from the provider side as well as the client. A couple other features to mention. If Andy had joined the conference before I had a chance to start it, I will get a message letting me know that Andy's joined before me and I have somebody waiting for me. It's our response to a virtual waiting room. This was sent directly to my Outlook email, letting me know who's arrived, the date and time of the service, and some simple confidentiality messages. We wanted to make it as seamless as possible for the client, so all they're going to receive is that link, instructions on how to enter the conference, and their password, and they can open it through that text or email, again, on any device that they see fit. The other option that they have, if they're using a client portal account, which is another piece of our client engagement toolkit, they will have the ability to open a video conference from here, and it will present their password for them here as well. We have the ability through those conferences to go through the signature process for a client. So if I wanted one of my patients to sign a treatment plan for me while we're on the phone, I can ask them to review it. It's going to present them a print view only of the message, or of the plan in this case. They can review and then sign without ever having to leave the comfort of their own home. So I think from what Deb has said, there's a few different things we've tried to accommodate. This is, again, a relatively new feature for us. We wanted to offer the ability for our own clients to have a bit more of an integrated approach. And we also wanted to make sure it didn't affect productivity. The training of it is relatively simple. We'll walk you through how to add the ability to start a video conference, choose which services it should apply to, and choose which user should have access. It really gives you the ability to remove some of that prep time. You're not going to lose any productivity related to documentation or getting to and from the location of the appointment. It's all integrated directly into our clinical workflow as they stand now. Not only does that simplify the productivity component, but it also ensures that you're sending out the bills as appropriately as possible with all the information that you need, so you can make sure to maximize the reimbursement for those services that you're providing. So Deb, I'm going to hand it back over to you. I know we're going to go into a bit of a Q&A.
Well,
Great.
thank you.
Everyone hear me? I think, yes.
Yeah, I'm going to jump in. kind of moderate the Q&A part. So we're going to open the session up for some questions and discussion. As reminded at the beginning of the broadcast, you can use the question and answer box in the GoToWebinar panel on the right side of your screen. And we do have a couple of questions already queued up. I will get into those, and if you have other questions, please feel free to use the panel to ask them. Kind of starting with, let me make sure I've got the right ones here. This may be, so this is kind of about functionality. This may be answered soon, but I'm wondering how easy this is on the client end. Our clients need to be able to open from one link or app. They may not have the ability to use a browser. So I think that goes into the patient ease of use.
Sure. So you're going to choose whether it's through the text or email, but the link for the actual conference is going to show up the same way either way. Whatever device that they're going to use, whether it be a desktop, a laptop, phone, or tablet, will take them to that browser. Almost every device at this point in time has a direct link to the browser, so they don't even have to open it. All they'll have to do is open their message through their email or text, click the link, and it's going to take them the rest of the way. I opened this in Chrome, so you saw that I joined via the browser. Some of the browsers do require a plugin, but it's a one-time download and save. That's why we tend to recommend Chrome to the clients, because it just adds one extra layer of simplicity to the process.
Great, thank you. This one's probably more for Deb. Why do payers want an increased use of telehealth or telemedicine?
Yeah, that's a great question. Payers, want to make sure that there's ease of access, and so they do see telehealth as a mechanism to really improve access. I know when I was working at Optum, if you could wait 4 weeks for a face-to-face visit with a psychiatrist, but with telehealth, there was just much broader access because there were more psychiatrists willing to deliver services through that convenient modality, right? It's convenient for the client and the therapist. The other reason is the data shows actually more efficiency with telehealth. So a typical number of sessions for outpatient behavioral health treatment might be 7 sessions, but it might be shorter for whatever reason with telehealth, maybe 6. So they're actually seeing more efficient service delivery. Now, I'm not sure if that's because traditionally individuals who are accessing telehealth may have had lower acuity than individuals who did not. Now that we have many, many more people using telehealth, we'll be able to dig into that question. So there's an efficiency component as well as an access component that makes it very valuable for payers. And actually, while I have the floor, one important comment that I didn't say is telehealth can really help reduce your no-show rate. Many provider organizations that I've worked with who implemented telehealth saw their no-show rates drop as much as 60%, because people can no longer say, I have the sniffles, I can't come in, I don't have transportation, I can't come in. So it can really dramatically reduce your no-show rate. And then last but not least, I am aware of practices, particularly intensive outpatient, who are seeing people engage longer via telehealth. I don't know if it's COVID related, because they're actually seeing longer engagement in certain treatment modalities. Maybe it is because of the convenience and being unable to leave your home, but I wouldn't worry when I say that it can be more efficient, that you're going to lose revenue, because one, you're going to open up new markets for revenue potentially, new populations and new geographies. And you should also reduce your no-show rate. I can't think of any organization that introduced telehealth that didn't reduce their no-show rate, which certainly improves your revenue.
And Deb, if I may, I think there's also kind of shifting demographics, and as the patient population gets a little bit younger, this is typically what's expected. I think primary care is probably a little bit ahead of behavioral health, but people are accustomed to having an online option. So that no-show rate's gonna go down for sure, but I also think we'll see higher engagement from the clients across the board.
Yeah, I agree, Rich. Yes, absolutely. I mean, this is going to be expected, right? I was able to access a lot of services during this COVID period via telehealth, and I'm not going to want to, now that it's one of those things that if you try it, you like it. I know the first time I used telehealth from as a client, as a, receiving services, I wasn't too sure I'd like it myself, and I felt like I was right there with my service provider. It didn't really feel any different. And I've heard children that were introduced to telehealth say they don't want to see their provider in the office. I remember a child who had been part of a pilot in Mississippi where we desperately needed telehealth. Their only psychiatrist was like 100 miles away. And when she finally met the psychiatrist, she said, can I just see you on the screen next time? I really don't want to. I would prefer to see you on the screen. I think people behave differently too. They're a little more open. There's something about being comfortable in your environment that allows you to, maybe be a little more open and expressive when you're behind the screen too.
Great. We have a couple of questions about integration with other EHRs. So planning with other ones or integration with Credible. So do you want to touch on that for a minute?
Certainly. So our standalone client engagement toolkit is designed for that exact scenario. There obviously will be a little bit of data that needs to be shared, which could be at one time or more frequently, depending on what makes the most sense for that program. And it gives you the ability to use a HIPAA compliant system. You can even document notes and in ours if you want it, and have access to some of the other elements like the patient portal and appointment reminders. So we know that making a big switch to a new EHR isn't an easy process, and it might not be the right time with everything going on with COVID. So we wanted to make sure we offered an option for those who weren't ready to make a change and wanted to use certain elements of the Welligent system in conjunction with their current EHR.
Great. There was a question about having multiple patients or family members join a therapy session. So there are multiple screens available. So I guess like the checkerboard window. So that was a question that was sent through.
So that's exactly right with the checkerboard window. It'll be a tile view. Basically, you can either schedule an appointment with all of those participants, or maybe you're looping some people in from an existing individual. You can add multiple participants from the family contacts in the record for the client, or you can bring in somebody from a referral source. So it's really trying to make sure you have the ability to pull in all of those stakeholders in care, whether it's for a treatment plan review, maybe preparation for discharge, but gathering everybody face to face, the ability to share the screen, sign documents, and complete your documentation right along the way.
Okay. Can you see or talk to a patient while doing notes? That was another question.
Absolutely. I wanted to keep one screen rather than using the second monitor for this, just so you could see what I was walking through. But whether you use one side of the screen for your note and one side for the video conference, or you use two monitors, it's all going to be available concurrently. You do not have to go to the video screen, switch over to your note. You can see them at the same time, document while you speak with the client.
There's some garbling on your end, Rich, if you could check that. I'm not sure where that's coming from. Is there a whiteboard feature while talking to a patient? That's kind of an interesting question.
There is not right now. However, we have kind of discussed that. I think the ability to share the screen gives you some flexibility there, but that's something that would be down the road for Welligent.
Okay. Sorry, there's a whole bunch coming in. Like I'm trying to keep up. So
yeah, keep going, David.
Administered by a public system administrator such as LA County, have you had any success interfacing with these systems? So
I don't think at this time we've integrated anything with the county. However, an old long-time Welligent client, Los Angeles Unified School District, is using this for their patient population. Obviously, they faced some interesting months due to COVID. However, everything is integrated. So from the video conference to the note templates to how that turns into a bill, all are within one single system. So I would say integrating with the county would be no problem. We just haven't done that yet.
So another question is, what new services should we, the providers, be focusing on growing? It looks like besides one-on-one and group, is there anything else that they should be looking at?
Hi, this is Deb. I mean, definitely one-on-one and group. And I think the question around group was, can you see all the faces, like you said, on a single screen? It actually works quite well. I do think, prior to COVID, intensive outpatient, what I'll say, was not typically delivered virtually. There were a few exceptions. That has happened post-COVID, which is typically a 3-hour session, 3 or more times a week for 9 hours a week. And that, I think, I'm trying to get out my crystal ball. I think payers will continue to support that as long as the data suggests that the effectiveness rates are the same. And by effective, I mean, you should be continuing to measure and monitor things like readmission rate and engagement in treatment, and transition from intensive outpatient into outpatient and continuing care. It's the engagement rate and continuity of care rate. I do think payers will continue to support that. I'm very curious. They're currently supporting, many of them are supporting partial hospitalization delivered through telehealth. That's a much longer period of time, right? That's usually 5 hours a day, 4 to 5 days a week. So it'll be interesting to see if they can continue to accommodate that. Again, it's back, the proof is in the pudding, right? Is there, as providers, we need to advocate and compel the payers to, look at the effectiveness during this window. If there's not been any market change, if you will, in, progress and effectiveness, I think that we can consider they could continue that as an option for individuals, or maybe I would be definitely thinking about a hybrid option of having both face-to-face services and telehealth services. It may create a little challenging environment for the organization to figure out scheduling and staffing, but I do think the hybrid model has a lot of strength for the consumer, right? I have some choices. I might want to do some face-to-face time, but there may be periods when I can't, and having the convenience of staying connected in my recovery journey is also important as well. So a lot of things to be considering, not just what you purchase as a tool, as an integrated tool, but how is this going to change your entire staffing model and approach to care, right? And given that it's likely that the consumer is going to want to continue this approach for all of the advantages it offers, and I think the payers will be compelled by their employers and other funders to consider more flexible options.
Some other things that stuck out to me, Deb, I'd be curious of your opinion on this, but I think residential providers, especially those that might have a lower level staff like a DSP working with clients in the home, especially in the era of social distancing, the ability to incorporate other clinicians or even physicians from a separate location. I think that's kind of a compelling argument for telehealth in a variety of behavioral health disciplines. The other, I feel, is crisis. I think whether you have a mobile ACT team or anybody who's going out into the community, whether it's a homeless population or anyone who's encountering a crisis that needs some support, you can bring in multiple resources and actually share face-to-face, getting a little bit more information about the context of a crisis. And I would imagine that the payers are going to see that pretty clearly.
That's a good point, Rich. And then even inpatient settings, right? It's inpatient attendings and psychiatry support. We're at a point where it's maybe the only way you can get staffing accomplished, right, is through telehealth, because there's such a demand right now in the market.
So is there, one of the other questions, again, we have a ton of questions that have come through. There's a lot of great stuff coming through the panel. Do you have electronic prescription features such as Doctor First?
Welligent integrates Change Healthcare for e-prescribing and e-labs. You would do that off of the note, just like you would document your note content in the same manner. So if you wanted to prescribe meds while speaking face-to-face with a client, that is one click away.
Great. So does this interface also support online signing of informed consent and authorizations to disclose patient information?
Yes, it does.
Great. You already answered the question about increased use of video by call center and crisis hotlines. Here's one: is the patient portal customizable?
Absolutely. In fact, everything that you saw on mine, I just had everything turned on. The Welligent system is really based on the principle of how simple can it be for an agency to take ownership of the configuration. So making choices like, do you want to allow secure messaging between providers and clients? Maybe you want to hide all billing details from the client. So it's really a matter of deciding what you want and what you don't want, and it's simple checkboxes for what's revealed.
Okay, there's another question about demoing. Could you demo how to pull another provider into a patient visit? So e.g. a warm handoff or a quick consult.
Certainly. If I can steal the screen back. So I'm going to jump back to my data at a glance, and I'll do my Rachel test client, open up her individual note. And this is going to work the same way regardless of which note we're using. But if I know that I'm going to get ready to meet with Rachel and I want to do my warm handoff, rather than just starting the conference from here, instead I'm going to manage. I'm going to add participants. I would find a contact from my list of referral sources. So this is my demo environment. I might not have too much based in reality here. Let's just say I want to search for a social worker. Pull in anybody that fits that parameter. Doesn't look like we have anybody there, so let me just pick probation officer. No one there either. Great demo, Rich. So I would pull in that contact. I would make sure I have the information I need in order to send this to them. So if you knew that bank test was somebody you wanted to reach out to, I would simply instead use the other. I would put in test bank, and I'll assume it's the test at Gmail. That's going to add them to the list. It's going to tell me that they're one of the other types. And then as I refresh this, I'll make sure I have the right email so that I can send it right out. And then I can start my conference. So you can do this with multiple people. If you needed to say, I also want to bring in Rachel's mom. I thought her name was Nancy. Let's pull in test. This is going to search through her record, pull out the appropriate contact. You would add them over just like you'd add somebody from the other category. And then you're ready to go. The only practical limitation for the amount of group is how many people you'll see on the screen at the same time, much like any other video platform.
Great. We've had a couple of questions about, I guess, payments and credit card usage. So I guess the summary one is, how do you charge a credit card after, do you charge a credit card after each teletherapy session, or does the patient have to give it to you every time? Is the information stored, I guess, is the crux?
Sure. So we do have the option to pay by credit card through our portal. It does not store the information. So you cannot set up recurring payments. However, we see that as a benefit rather than a detriment. So you will be required to put in the card details each time, but you can easily apply a fee for video conferencing if that's something that you wanted to do, or they can pay for their copay through this as well.
Let me look through. I'm sorry, there's a long list here. I think we got most of them. So I think one of the last ones remaining is, do you recommend any in-person sessions or meetings that would help verify identities in case there is an emergency situation that would need to activate emergency services or law enforcement or crisis intervention?
I think that's probably more of a Deb question.
I'm sorry, what was the question? I apologize.
Recommending it like an in-person session, I guess, prior
Oh,
to a telemedicine visit that would, to verify identities in case there's an emergency situation that would need, crisis intervention or law enforcement, something after later on.
yeah, some of the states, Ohio comes to mind as one of the few states that previously, pre-COVID, required a face-to-face visit before, implementing telehealth. And certainly the clinician should evaluate, if the individual is, really able to participate, right? You could have someone that just, I don't know, say an autistic child that just is not able to engage, although there's definitely some tips and tricks on that as well. But I think as long as at the top of the session, I mean, in Welligent system, Rich, I'm sure you can capture emergency contact information. And I think if you start the session confirming where someone is, right? Are you at home today? So that if should a crisis come up, you would be able to, contact 911 and engage whoever needed to be engaged. So I don't feel like you have to have a face-to-face as a first session. There's certainly many sessions pre-COVID that were occurring without that. It's just important to have emergency information. I don't know if this system would be able to tell you, Rich, the location of the individual electronically by any means, but like a GPS tracking, but which would be unusual. But beyond that, I think you can accommodate that by just being, you should always know, right, where they are, where the individual is should an emergency come up and who their appropriate contacts are.
While we do have electronic visit verification for our providers' notes, we don't include that for the client. And I think, especially in mental health, especially in conjunction with some of the COVID restrictions that have been imparted, most clients really don't want to have the ability for somebody to track them through GPS. So obviously all the elements of that family contact list, the emergency contact list, and home location of the client are available in their demographic record, which is presented on the note. So I think other than the GPS, we would handle everything in that workflow.
Great. There's one sort of pretty specific question, but I'll put it out there anyway. So is there any integration with this and an avatar by NetSmart?
We have not yet, but I imagine that there will be a variety of behavioral health EHR users that are going to fit that category. So it would be the same as we would handle something with Credible or any of the other behavioral health EHRs. It's really just an interface for the data, since you'll be doing most of the video conferencing and some of the kind of supplemental elements like messaging and appointment reminders, or the use of our portal to move some of that data over, so you had client records to verify and reference, and you'd be able to use both systems.
All right, excellent. I'm just scanning through. I've got to scroll down like basically 2 pages of questions. I think we've covered everything that has been asked. So at this point, if there's nothing else, I want to thank all the participants today. This has been a great session, very engaged. Thanks to Deb and Rich for presenting us the how to successfully integrate telehealth into your clinical workflow, which has been brought to you by Welligent and Open Minds. So just as a final reminder, all participants will receive an email in the next few days that contains a link to allow you to download a PDF copy and an audio recording as well. So thank you all and have a wonderful day.
Thanks, David.